I'm Robin Riddle. I'm with Brain Support Network and also with Stanford. And I'd just like to briefly tell you about those two organizations. Brain Support Network runs a local Lewy body dementia caregiver support group here in the San Francisco Bay Area. And we invite people to join us either in person or virtually. We alternate between in-person and virtual meetings. And anybody in Northern or Central California is welcome to join us for our Lewy body dementia caregiver group meetings. And then we also work nationally to help people with all kinds of neurological disorders donate their brains or their loved ones' brains. And so we've done over 1,400 brain donations to date, and we'd be happy to help anybody in this room or on the call with a brain donation. Also at Stanford, I run a Parkinson's community outreach program. And we have Parkinson's support groups, caregiver support groups, and Parkinson's, anybody in the community support groups that meet locally and virtually. And we have a website with a lot of great exercise class lists and other resources on it. So we're glad to have anybody access our resources that way. So we're so glad to welcome you today to the Lewy body dementia caregiving symposium. And our first speaker is Dr. Poston, and we'll have two speakers this morning, Dr. Kathleen Poston giving an overview of Lewy body dementia, and then Christina Irving, a licensed clinical social worker from Family Caregiver Alliance. Then we'll take a short lunch break, and those of us here at Stanford will enjoy a lunch, and I hope people on Zoom can enjoy a lunch or exercise or something. And at the time we take that lunch break, I'll announce what time we'll be rejoining, but probably we'll just take a half an hour lunch break is my expectation. And then after lunch, we have a great caregiving panel set up with 5 caregivers. So we look forward to that. And we have in the meeting room, we have green cards, fluorescent green cards to write your questions on. And if you have need for other cards, just raise your hand. And once you have a card filled out, if you could just raise your hand with the card, somebody will come around and pick it up. And we'll save time at the end of both of the morning speakers and at the end of the panel to answer questions. And those of you on Zoom, please submit your questions by the Q&A box, and we'll address as many in-person and Zoom questions as we can. So I'd like to introduce our first speaker. It's Dr. Kathleen Poston. She's the chief here at Stanford of our Movement Disorders Division. Kathleen.
Hello, good morning, everyone. Okay, so is there any way to do it where I can actually see my presentation as it goes on here? Perhaps. Yeah, I just don't even see where it is on here. There's just a lot of stuff open. Yeah, so where actually is the presentation? Sorry.
Right here, yeah.
So I can close this?
You can close that, yeah.
All right, so there's a couple of them here. Yeah, there's 4 PowerPoints.
Yeah, that's you.
So is this the one though that's going?
That's the one that's going.
Okay, so yeah, but it's not in presentation mode.
Yeah, it's funny. The slideshow.
Yeah, but it's in slideshow, so I don't know where that's coming from.
Don't either.
I just
close is what you want.
Okay. All right. One moment, folks. So sorry. Just want to figure out.
Whatever that means, ignore it. Yeah, go back to there.
Okay, there we go. Yeah. Got it. Yeah, that's the one I want. Okay, perfect. Sorry. Okay, we found it. So I'm Kathleen Poston. I am the chief of the Movement Disorders Division here at Stanford. And just to show you sort of who all the Movement Disorders Division is, this is our team. And I want to point out we have several, let me see if I can get a pointer going over here. Here we go. We have several new faculty here who have started in the last 2 years. I know that our capacity for new patient appointments has been very, very limited in the last couple of years. We had an enormous amount of turnover during the pandemic, with folks, physicians leaving California. We were not immune to the great exodus from healthcare, unfortunately. But we've had an amazing opportunity to recruit some just absolutely fabulous physicians to our team. And I want to point out here one person in particular, Dr. Jocelyn Jiao, who is the first neurologist in our department who is co-board certified in neurology and palliative care. She did 2 years of a movement disorders fellowship and then a 1-year palliative care fellowship. So she is dual boarded and will be starting actually in October, so starting this month, has a neuropalliative care clinic 1 day a week in the Neuroscience Health Center here on campus. And so if someone is interested in a referral to neuropalliative care, that is now available, and your physician, if you are in the Stanford system, can see her as one of the options to select. I also know that Kaiser has a wonderful palliative care referral center as well. So those are great expansions. I also want to point out that, you know, I'm going to be talking about the intersection a lot between movement disorders and behavioral neurology, which are two traditional fields within neurology. But dementia with Lewy bodies sits in between the two of them. And it's one of several neurodegenerative diseases that sits in between movement disorders and behavioral neurology. And we're very lucky here at Stanford in that the behavioral neurology division, which is led by Dr. Sharon Shaw, and my division, movement disorders, actually are incredibly integrated and interact with each other. I'm actually formally also a member of the behavioral neurology group, and Dr. Shaw is also formally a member of the movement disorders group. I also am a co-investigator on the Alzheimer's Disease Research Center, which is funded by the NIA, and we are the only ADRC in the country that simultaneously recruits people across the Alzheimer's spectrum, the Parkinson's spectrum, and the dementia with Lewy body spectrum. And so we here at Stanford see these two artificially separated subspecialties in a very integrated way. We meet weekly with I'm frequently at the memory disorders case conference. The memory disorders doctors are frequently at the movement disorders case conference. We work very collaboratively together. So I didn't have all their pictures to put up on here because this is a slide that I have, but both of those two groups are very, very integrated together with one another here at Stanford. And this disease, Lewy body dementias, is one of the reasons why that is. Because in my opinion, this is kind of the quintessential neurodegenerative disease that requires expertise from both those fields and knowledge of both of those. So just want to point out that we are a Lewy body Dementia Association Research Center of Excellence that Dr. Shaw and I co-direct. We always make sure any neurodegenerative disease centers of excellence that cross the boundary between movement and behavioral, we have one person trained in behavioral, one person trained in movement who co-direct the centers. And so Dr. Shaw and I co-direct that. And so, and this symposium is funded in part by our Lewy body Dementia Association Center of Excellence, and part of our mandate to be educational providers to caregivers and community members. Okay, so what am I going to talk about today? Let me get my little thing back. There we go. Okay. Oh, and I would like to just point out that these slides were wonderfully put together by a fabulous physician scientist in my lab, Carla, who is here today joining us as well. So the slides, I give all credit to her because she took my slightly complicated presentation and got it down to like some wonderful focus slides. So I'm much indebted to her for putting that together. So today we're going to talk about the Lewy body dementia definition, the diagnosis of Lewy body dementias, and then talk a little bit about the patient's journey within the process of Lewy body dementia. And through all of this, I'll sort of makes particular notes to sort of how this all interacts with the caregivers. So first of all, the definition. So let's just break down the word. Lewy body dementia. Okay, so we're going to talk about those different pieces. This is a neurodegenerative disorder. That's a term that I just used a few minutes ago, neurodegenerative diseases. And I'm just going to give you a super complex slide in a moment here. So these are all the neurodegenerative diseses of aging that we think about here across the movement disorders and behavioral neurology group. We've got, and right here in the middle, again, in the red box, these are Parkinson's disease and dementia with Lewy bodies. All right, so we're going to go through a little bit about how we get to how we think about those. Let's first focus on the first word, Lewy body. All right, so where does that term come from? So it turns out that in the early 1900s, neuropathology was a field that was really just starting to develop. And there were a couple of very meticulous neuropathologists who had been gifted the brains of individuals who had died of dementia. And in looking at those brains under the microscope, they noticed these things here. And so this right here is a Lewy body inside of a neuron. This is actually a great picture of it because you see the pink kind of perfectly circumscribed like little blob there inside what is otherwise a normal looking neuron. So Dr. Lewy noticed these little pink blobs that were inside the neurons in areas where it looked like there had been the loss of these nerve cells and that there had been some damage and death to nerve cells. And then occasionally he'd see like a little Lewy body just kind of floating out there without a neuron around it. And so the conclusion he came to was that these neurons developed these Lewy bodies and then the nerve cells died, and that was kind of what happened as somebody developed Lewy body diseases. And so that's where that term came from. All right. And so within all of this, it was determined that these two clinical syndromes, Parkinson's disease and dementia with Lewy bodies, it turned out both of them somewhat almost indistinguishably had these Lewy bodies across the entire brain at the time of death. And so when a pathologist would get a brain and look at it, whether they had a clinical diagnosis of Parkinson's disease or a clinical diagnosis of dementia with Lewy bodies, they had these Lewy bodies in these particular areas of the brain throughout the brain. Fast forward about 100 years to 1998, it was identified that Lewy bodies contained the protein synuclein. So you're going to hear that word sometimes, synuclein or synucleinopathies. And so that's that thing up here. These are the proteins that are associated with these different neurodegenerative diseases. And alpha-synuclein in particular is the protein that's inside of that. That was a discovery in 1998. And so that's really spearheaded a lot of work to try to understand synuclein. It turns out synuclein is a super important protein in all of our bodies and brains. It's a protein that helps nerve cells communicate from one to another. What we don't know, and this is like the Nobel Prize winning question, is why that synuclein changes its conformation and clumps together like that into a Lewy body. That's the big mystery that we don't understand. We know alpha-synuclein is absolutely critical to normal brain function. Why? How does it change conformation, clump together? And then what's the relationship between that clumping together and the death of the nerve cell? We don't know those answers yet. Those are critical answers, but we don't know them yet. So from a terminology perspective, the word Lewy body dementia includes both individuals with Parkinson's disease dementia and dementia with Lewy bodies. And that is incredibly complicated and has confused the field beyond end. And if you are confused, you are not the only ones. Physicians are confused, neurologists are confused, and basically what these terms came from was the clinical setting that patients were seen in. So people who had classic Parkinson's disease, so tremor, slowness, and stiffness, but no memory or thinking problems, some of them developed mild cognitive impairment, and then they would progress on to develop dementia. And so those people had Parkinson's disease with dementia. Other people seem to kind of fast track all the way to the dementia with maybe a little bit of the slowness, stiffness, but not necessarily a lot. And then there are some people who had none of the slowness or stiffness. They just kind of fast track straight to the dementia. And so that term, Lewy body dementias, encapsulates both of these. And the timing of the motor first versus cognitive first is the only thing that actually distinguishes these two. And then just to make the whole conversation more complicated, all of them are called Lewy body diseases, right? So you have Lewy body dementias, which includes dementia with Lewy bodies and Parkinson's disease dementia. It is a acronym word salad that we are trying to get ourselves out of. And I hope that myself, with work with the Michael J. Fox Foundation and the Lewy Body Dementia Association and many other organizations, the European Lewy Body Association, we are trying to find a better nomenclature to sort of find our way out of this. But that is where we are right now. So this is the terminology. So there's no such thing as having Parkinson's disease and dementia with Lewy bodies. You just have one, and it's based on the timing of which came first. But Parkinsonism, the slowness, stiffness, and tremor, can be part of either one of those. So I hope that slightly clears up the salad. No, okay, sorry about that. So the differences between a symptom and a disease. So Parkinsonism is just a symptom. So for instance, you can have tremor, slowness, and stiffness due to a side effect of medications. You can have slowness, stiffness, and tremor due to a stroke. You can have slowness, stiffness, and tremor due to Parkinson's disease. So that's just a symptom. That's a syndrome or a symptom. You can have slowness, stiffness, and tremor as part of dementia with Lewy bodies, or you can have slowness, stiffness, and tremor due to traditional Parkinson's disease. So that's the difference, is symptom versus disease. And the problem is we're using the same word, Parkinsonism and Parkinson's disease, for both, and that's not very helpful for anybody. So not my fault. I didn't pick the nomenclature. I'm trying to fix the problem, but it's taking a long time. Okay. So what we don't always understand is why some people have this very fast progression to dementia and other people can take 20 years to get there or more. There are people I take care of who have Parkinson's disease who didn't develop cognitive impairment and dementia until 30 years into their Parkinson's disease. I have other people who I diagnosed with Parkinson's disease who developed dementia within 3 or 4 years. And then I have other people who have that cognitive dementia first, who have that more dementia with Lewy body phenotype. We don't really understand why some people go to the dementia very fast and other people it takes 20 to 30 years. That's another very big unknown that my lab and many research labs across the country are trying to understand. So I've used 3 terms: normal cognition, mild cognitive impairment, and dementia, but I haven't defined them for you, so I'm going to define them here now. When I'm thinking about the level of cognitive impairment that somebody is experiencing, there are 3 questions that we ask. The first question is there a cognitive complaint or change according to the patient, a family member, or the physician? So is this person noticing something? Is the family member noticing something? Am I, as the physician, noticing that this person is having a harder time doing something, whether that's organizing their day, or is that coming up with the right words at the right time, or is that remembering appointments? Is there something that they are having a harder time doing now than they used to? The problem is that can be, for all of us, the problem. That is part of the normal aging process, that there is normal aging cognitive changes. And I will say that the word finding one is the most common for all of us as we get older. So there's age-related cognitive changes that happen. So just because you recognize something doesn't mean it is a disease. It could just be normal aging. So if somebody has no cognitive problems, no cognitive complaints, my cognition and thinking is exactly the same as it was 10 years ago, they perform normal on cognitive tests, and no cognitive problems with their day-to-day activities, we call that normal cognition, okay? But then what if somebody has a cognitive complaint? So number 1, they have noticed a change. That's why we pull in official tests. So these cognitive tests are normalized to your age. So it's the same test, but the expectation changes whether you're a 30-year-old or a 60-year-old or a 90-year-old. So an example of the test is having these 20 words that you have to remember, and then you're asked to give them back 5 minutes later, and then you're asked to give them back 20 minutes later. Well, what would normal be for somebody who's 50 would be very different than what normal would be for someone who's 85, right? And so it's their age-adjusted expectations on the tests. And so if you have mild cognitive impairment, that means that you've noticed something's different, your family's noticed something different, or the doctors noticed something different, and the tests are scoring below what we would expect for your age. So maybe you're that 60-year-old, but your test scores are what an 85-year-old, what we would be expecting. So that's this cognitive test. So that's mild cognitive impairment. It's only considered mild cognitive impairment because you don't check the box for number 3. You can still do your activities of daily living. You've noticed something, but it doesn't stop you from doing anything. You can still drive, you can still cook, you can still pay the bills. You just kind of notice it's a little harder, it's a little slower, maybe you have to ask for help occasionally, but you can still get it all done, right? It's just a little bit different. It's mild cognitive impairment. The definition of dementia is anything that transitions from just being not testing as well to your day-to-day activities are impacted by the cognition. So you can't pay the bills anymore because of your cognition. You can't organize a recipe or cook anymore because you can't follow the recipe, or you can't remember what thing you did 5 minutes ago to know what to do now. That's the definition of dementia. Many things cause dementia. Strokes can cause dementia. Many neurodegenerative diseases can cause dementia. It just so happens that Alzheimer's disease is the most common cause of dementia. And so oftentimes people just assume if someone has dementia, it's Alzheimer's dementia, but those aren't the same thing. Again, dementia is a syndrome. It's a symptom that I'm defining by behavior that can have lots of different diseases that cause it. And Alzheimer's disease is the most common. And in fact, people are trying to, speaking of names, have people calling it Alzheimer's disease now instead of Alzheimer's dementia to try to separate those two things. The acronym is still the same, AD, but they're trying to use the term Alzheimer's disease instead of Alzheimer's dementia because it's just everyone thinks that dementia equals Alzheimer's dementia. So Lewy body dementia and Parkinson's disease dementia are two causes of dementia, and in fact, they are the second most common cause of dementia after Alzheimer's disease. And so I put things into 3 different categories: normal cognition, mild cognitive impairment, and dementia. But it's not like people just wake up one day and they've transitioned from mild cognitive impairment to dementia. It is actually a continuum. We just kind of put these boundaries around it so that we can use terminology a little bit more clearly. But I will tell you, it does tend to be a little bit more of a kind of back and forth, that people have a good day and then they have a bad day, and then maybe the bad days are becoming more frequent and the good days become less common, and maybe that's when the transition to dementia is happening. And in our research studies, we debate this, whether we're officially going to call somebody dementia or not, or maybe they just, we're seeing some little hints, but it's not quite there. So it's not a clear, like, and now you're in this phase kind of thing. It's a little bit more gradual. And again, really, it's a continuum. We've just put labels at different phases. And I will say that physicians disagree as to whether someone has officially transitioned to dementia or not. Probably one of the most hotly contested conversations we have at our meetings, at our research meetings. Okay, so take-home messages. Number 1, Lewy body dementias are neurodegenerative diseases. The cause are the abnormal deposits of this protein alpha-synuclein, which forms these Lewy bodies, which are the circles. There are also these Lewy neurites, which are kind of the same alpha-synuclein clumped, but more in a line rather than a circle. It is a continuum across the neurodegenerative disease model, and it's important, of course, to identify patients at as early stages as possible. And this very complicated term, Lewy body dementias, encapsulates both dementia with Lewy bodies and Parkinson's disease dementia. So how do we diagnose it? So I'm going to show you another complicated slide, and then we're just going to move right past it. This is the official diagnostic criteria for dementia with Lewy bodies and Parkinson's disease, highly overlapping. The only real difference is whether the motor symptoms come first or the dementia comes first. But right now, it's mostly based on a clinical diagnosis. And so it can be very complicated because not everybody read the textbook and has the symptoms that perfectly match what I have listed here. Everybody's different. One of the really, really important things that I try to iterate with my trainees is that if you've met one person with dementia with Lewy bodies, you have met one person with dementia with Lewy bodies. And if you've met one person with Parkinson's disease, you have met one person with Parkinson's disease. Every patient is a little bit different, and that makes it very complex to diagnose. And again, dementia with Lewy bodies, dementia occurs before or at the same time as any motor symptoms, whereas in Parkinson's disease dementia, the dementia occurs after somebody's had the motor symptoms for several years. So it's really this balance between time, that many patients will eventually have both the symptoms of the cognition, which is associated with sometimes with hallucinations, and then the motor symptoms associated with traditional Parkinson's disease. Okay, so we'll just dig a little bit deeper. Somebody comes to my clinic and I'm trying to make the diagnosis of Parkinsonism. Again, that syndrome. Oh, something came up here. Hold on. One moment. There we go. And then something came up here.
I think it's this flash drive.
Okay, excellent. Thank you. Okay, so as I said, there's the syndrome of Parkinsonism, which encompasses 4 different motor elements. I keep using the word slowness. The official doctor word is bradykinesia, brady meaning slow, kinesia meaning movement, slow movement. There is rigidity, so that's stiffness in the muscles, often in the arms, but can also be in the neck, the trunk, or the legs. The tremor, which typically is a tremor when the hands are resting, but can also occur when someone's reaching for things. And then abnormal gait and posture. You see this little cartoon, the person's a little bit hunched forward. That forward hunching is one of the characteristics, with small shuffling type of steps. That combination, if you have the bradykinesia, the slowness, plus any of these others, that gives you the syndrome of Parkinsonism. But in addition, there's all of these non-motor symptoms that can happen in somebody with either Parkinson's disease or with dementia with Lewy bodies. You can have loss of smell, constipation, sleep problems, sexual problems, pain problems, hypophonia, which is the doctor term for soft, low speech. You can have depression, anxiety, apathy. So these neuropsychiatric symptoms, it turns out dopamine, which is affected in people with Lewy body dementias, dopamine is really important for mood regulation. And so a lot of patients can have a lot of anxiety, and apathy is loss of interest in things. So it's not depression in the terms of like the sadness. It's more the just, yeah, I just don't want to do that. I just don't want to do anything. I know I used to like golf, but I just don't feel like it. I just don't want to. That's apathy. That's actually probably one of the most common ones that we see. Urinary symptoms, excessive sweating, excessive salivation and drooling. Dysarthria is kind of a slurred speech, inability to pronunciate words. Dysphagia, difficulty swallowing. And then these other more severe cognitive symptoms, dementia, psychosis, they can also be blood pressure changes upon standing. This can be a really severe symptom where people feel super lightheaded every time they stand up, and more severe urinary symptoms. The symptoms I look for in making the diagnosis of dementia with Lewy bodies is, again, this Parkinsonism that I already defined. And then a couple of other key things that we'll talk a little bit more in depth. These visual hallucinations, this very specific sleep disorder, and then cognitive fluctuations. So again, we already talked about the Parkinsonism. The way I determine that is by the history as well as the exam. So I look for certain things on exam. I ask about certain things on the history. And then some patients with dementia with Lewy bodies and many patients with Parkinson's disease dementia, if you give them the medication levodopa, some of these symptoms can get better. Levodopa, which is Sinemet, will replace the dopamine in the brain, and that will help the movements improve. And again, sometimes it is beneficial, but there are some side effects we have to worry about. 2 big side effects. One of them is that levodopa drops blood pressure. So if someone's already having those issues with low dropping of blood pressure, we have to be super careful with the levodopa. And then the second big side effect is that it can cause or worsen the hallucinations. And so we'll talk about, I think, those next. Oh no, fluctuations next. We'll get to hallucinations in a second. So I have to be super careful with the levodopa in people with dementia with Lewy bodies, because there's two things that they can have that it can make worse. So the cognitive fluctuations, this is, I think, one of the more difficult things to understand. But if you're a caregiver and you've seen it, you recognize that this is probably one of the most influential symptoms on a day-to-day basis. So it's defined officially as spontaneous alterations in cognition, attention, or arousal. That's like literally cut and paste out of the formal definition from the diagnostic criteria. It can include these waxing and waning episodes of behavioral inconsistencies, incoherent speech, variable attention, or altered consciousness that can involve staring or just completely zoning out. It's more intense than good day, bad day. Okay, anyone with a neurological disease can have the good day, bad day phenomenon, or good morning, bad afternoon. This is really like someone was like sitting there at breakfast doing pretty good, and then as you go to get them ready to go to the doctor's appointment, it's like you cannot get clothes on them, you cannot get shoes on, like they're just completely out of it and not interacting in any meaningful way, and that might be there for hours. And what makes it so difficult is that you can't predict it. You know, you can plan your whole day and think that you got everything organized and ready to go, and then all of a sudden you get these cognitive fluctuations, and it's like, yeah, the plans are out the window, the appointment's not happening, we're not doing that lunch. And that's what makes it so hard, is that it's unpredictable and it can be quite severe. As a physician, this is hard to really elicit. So if you're experiencing this, definitely talk to the physicians about it, because it's you know, if I ask the question, does the person have fluctuations? The answer is 100% yes, but that's not actually what I'm asking, again, because everyone has the good day, bad day phenomenon. It's a more severe form of that. And so it may occur kind of at any stage, but it tends to get a little bit worse with time as time goes on. We think maybe some of the medications to help with cognition might help a little bit with the fluctuations in consciousness, or cognitive fluctuations, but in the clinical trials, they didn't actually use this as an outcome measure. So it wasn't formally studied. So this is just kind of empirically, kind of by our experience, we oftentimes use. And the cholinesterase inhibitors, I'll mention them a couple times, are donepezil, which is also known as Aricept, and rivastigmine, which is also known as Exelon. There's another class of cognitive medication, memantine, which we sometimes use, but none of these were formally studied for fluctuations. So we don't have good data on exactly how often it works, how well it works. So I just know by experience, sometimes we get a little bit of benefit, but it's a bit of trial and error per person, which is very frustrating. So there's another core feature, the REM sleep behavior disorder, which is these active movements during dreaming. So when we all dream, you're actually paralyzed. Your body goes into this paralysis mode where you don't move at all. And for some reason that we don't understand, people with synucleinopathies, so these Lewy body diseases, lose that lack of muscle tone and they act out their dreams. And again, for some reason, it tends to be these aggressive dreams, like they were like fighting someone or sword fighting. It's always something a little bit aggressive or running from someone. Patients actually don't necessarily wake up from these, and they wake up remarkably well rested considering how much they've moved. It is incredibly disruptive to the bed partner, though. Even a little bit of REM sleep behavior disorder can be incredibly disruptive. You know, with someone all of a sudden punching across the bed from you. I have family members who, you know, so it always starts like, well, we just stick a pillow in between us and I hope that's good enough. But it can be quite aggressive. And I have had bed partners who have been punched in the face in the middle of the night. And so this is one that is more dangerous for the bed partner, honestly, than it is for the patient. It is possible for the patient to injure themselves. I've had somebody punch a headboard and break some fingers. I've definitely had someone throw themselves out of the bed and hit their head on an end table. But more commonly, I hear about minor injuries from the bed partner than I do injuries from the patient. There are two medications we give to try to reduce REM sleep behavior disorder. So melatonin is the first choice that my sleep colleagues recommend. And we actually go to pretty high doses, 15 to 20 milligrams, so much higher than what's normally used for just insomnia. Clonazepam works pretty well, but it is very sedating. So if someone has to get up to go to the bathroom in the middle of the night, they will be groggy and they will be imbalanced and it will be dangerous. It also, there's some data to show that people who are on chronic doses of this type form of medication, a benzodiazepine, actually can worsen cognition over time. And so I've become very, very conservative in prescribing clonazepam after that data came out about 5 or 6 years ago. If somebody is really injuring themselves, though, we'll talk about the risk of clonazepam versus the risk of self-injury. Honestly, it's the safest thing to do is just to put the mattress on the floor so that if somebody throws themselves out of bed, they're not going down 3 feet, they're just kind of rolling onto, the ground. But it's everything is a balance between risk and benefit. All right, good. We got to the hallucinations. Okay, so this is probably one of the most striking features of dementia with Lewy bodies and Parkinson's disease dementia, which really isn't present in other forms of dementia. And so about 80% of patients will have some version of visual illusions or hallucinations. So I use the word visual illusions because that's sort of the most mild version. And we've all experienced visual illusions. But you have your glasses on, it's dark, you see a bag in the corner, you think it's a cat, you look over and, oh, no, actually it's just my black bag sitting there on the ground, right? That's a visual illusion. We've all sort of looked at the pattern of clouds in the sky and can kind of see, a dog kind of coming out of it, right? If you kind of blur your eyes, right? Like that's a visual illusion. So the first kind of most mild version of hallucinations are enhanced visual illusions. Patients will look at patterns and things will just pop out at them more. They'll see things out of the corner of their eye. If it's dark, they're more likely to think that it's something in the room. But if you turn the lights on or you get better lighting, then they're actually realize that it's not there. So that's kind of those visual illusions. It then can transition into what we refer as fully formed visual hallucinations. I see a person sitting right there and I'm looking right at them and I see a person and I realize they're not really there because it doesn't make sense, but there's a person right there in that chair, that kind of thing. Typically people and animals, oftentimes small people or children, sometimes nice animals like cats and dogs, occasionally spiders, which is not so great, occasionally snakes. I've heard snakes a couple times. And so it kind of depends. A lot of patients have full insight into this. So when I ask them in clinic, the family member is oftentimes very shocked to hear that they are frequently seeing somebody in the room, but they know that the person's not there, so they never mention it. It doesn't scare them. It doesn't bother them. They've kind of figured it out on their own, that there's not a 4-year-old girl running around their house every night, and she seems kind of pleasant, so they just don't ever say anything. And so oftentimes there's a lot of insight on the behalf of the patients. And so if you don't ask, you will have no idea that they're experiencing this. And honestly, if it is non-disruptive, the patient's not scared of it, they have full insight, I generally tend to veer on the side of don't treat, because all medications have side effects. And if it's not disruptive and the patient's fine with it, then we'll just monitor. But then it can transition into, is it real or is it not real? Are those kids in the background really there, or is there actually someone back there who's like trying to steal stuff out of our trash? I can't tell. And that can become very distressful for patients when they don't know if it's real or not, or if they're convinced it's real and they need told that it's not real. And so there's a couple of things that we do. First of all, if hallucinations come on quickly or worsen quickly, the first thing I tell the family member to do is go to urgent care and check for an infection. So if somebody has a urinary tract infection, their hallucinations are like the first thing to get worse. They might not even feel any burning with urination. They might have no idea they have a urinary tract infection, but boy, if those hallucinations get worse fast, you go to urgent care and you check a UA and make sure there's not an infection that's happening. So that's number one. Another reason why they can come on really fast is another medication was started. So I've had a couple people who are doing really well and, are on a cruise, and their primary care doctor prescribed them that scopolamine patch to keep them from having any stomach, seasickness. And they put it on, and like an hour later are like wildly hallucinating. The scopolamine patch is known to potentially cause that, particularly in people who are vulnerable to it. And so that's a drug-related enhancement of the hallucination. So two things: urinary tract infection, make sure you didn't start any medications recently. And so if it's not those, if it's just kind of gradually worsening over time, and we talk about medications, then we think about some medications here. So one of them I mentioned earlier, levodopa or dopamine, can worsen the hallucination. So sometimes I will reduce that dose and the hallucinations will get better, right? So if somebody's on dopamine for the slowness and stiffness and that's helping, but the hallucinations are getting worse, I might lower that medication. So think about medications. There is one FDA-approved drug for hallucinations in Lewy body diseases. It was previously contraindicated in dementia because they hadn't done that study yet. That has now been removed, so it can be used in people with dementia. The name of it is pimavanserin or Nuplazid. The downside of it is that it's a pain to get because it's a centralized specialty pharmacy. And so like you have to work with the company and they ship it to you. And it just, the startup has always been very challenging. It also takes about 2 to 4 weeks to start working. In the clinical trial, at 2 weeks, the difference between the placebo group and the treatment group was separated, but not statistically different. And then at 4 weeks, they were statistically different. And so it takes a while. It's not like it's not something you would give and like that night it's better. Low dose quintiapine or Seroquel is the one that has a much more faster acting. It's been on the market for over 30 years. It's pretty easy to get. Technically, it's not FDA approved, so it's considered an off-label usage, but it is frequently used for people with dementia. It depends on the person. Some people have a really bad reaction to it. Some people really, really respond to it. Again, this is a trial and error situation, and that we don't have good data to predict which people will have a really bad reaction to it. So we have to just be very careful with giving it. And I agree, some people have had very bad reactions to it, so I have to be very careful. Similarly, the cholinesterase inhibitors, Aricept and Exelon, so those, again, they did not look specifically in the clinical trial if there was improvement in hallucinations, but everyone in my group and in the behavioral neurology group have had some patients who have improved. So it's kind of, again, we sort of figure out which medication is the best option for which patient in which situation. Okay, moving along. Let's talk a little bit just about testing and diagnosis. So as I mentioned, we define clinically, I just gave you all the definition, and that is really hard to figure out all of those things in a 45-minute appointment, right? I mean, this is why the diagnosis of dementia with Lewy bodies and Parkinson's disease dementia is so darn hard, because every patient has different versions of all of these symptoms. No one has the exact same constellation. So a lot of work has been done over the last 15 years to try to come up with a biological way of diagnosing patients. And that has been quite difficult. But we do now have a marker that can identify people with synuclein who have the synuclein disease. We can't actually see it in the brain yet, but we do have a way to do this. The most validated version is doing a lumbar puncture, so it's not easy. And then there's also a skin biopsy test that can be done. The advantage of the lumbar puncture is that they can also check for the Alzheimer's protein, so amyloid and tau. So you can check for amyloid, tau, and synuclein. But I will tell you right now that the synuclein one is not paid for yet by insurance. It is not covered, and I think it's $1,200. So it's very expensive, and it requires a lumbar puncture. So if somebody already has a diagnosis and your doctor feels very confident in that diagnosis of dementia with Lewy bodies, I don't necessarily recommend doing this. I've only probably done 5 in my entire clinic since this became approved a little over a year ago. Okay, so I just do it when I'm really unsure. Is it Alzheimer's disease? Is it dementia with Lewy bodies? I'm not really sure. And then I will test for this, and the family and the patient really want to know. I'm not going to go through the details on how this works, but basically it comes up with a yes/no kind of answer. You sort of see the aggregation of the synuclein or you don't. So it's either detected or not detected. I'm just going to quickly go through this part because I want to get to some other stuff. There's also a couple brain scans, but they are non-specific. So there's a way, this is a dopamine scan. As I mentioned, people with dementia with Lewy bodies have reduced dopamine in the brain, just like people with Parkinson's disease have reduced dopamine in the brain. And so there's a dopamine scan that can be done. This is pretty simple to do brain scan, which can help with the diagnosis. You wouldn't expect to see the loss of dopamine in Alzheimer's disease, for instance. There's this other test that looks at the uptake of something in the heart and the lungs. It's a very hard test to get, so I don't order very many of those. For REM sleep behavior disorder, this is a very complicated slide, I apologize, but you can get an official sleep study is the best way to formally diagnose REM sleep behavior disorder. I don't do that unless I'm unsure if it's sleep apnea or REM sleep behavior disorder, because I would treat those differently. And some people have both, and I can't tell just based on the history. Okay, so the cognitive impairment that patients experience, whether it's Parkinson's, dementia, or dementia with Lewy bodies, tend to be in this same type of area where it's more of the executive function, more of the attention problems, and more visual spatial, and a little less problems in memory and language. Alzheimer's disease tends to be more of the memory and language and less of the stuff up top, but it can be very difficult to differentiate between those two things. We can do formal testing to try to differentiate between them, but even then, I will say that, again, in our research group, we will argue over whether we think it's more executive versus memory or memory versus executive. It's not always straightforward. This is just a consolidation slide of all those medications that I mentioned before, the cholinesterase inhibitors, which again are officially approved for both Alzheimer's disease and have been well tested for Lewy body dementias. Okay, there's also some things that that can help you in the doctor's visit. There's this program that's been developed with the Newcastle group called Diamond Lewy that gives a bunch of different things that every doctor should do during a Lewy body dementia appointment. This has been very helpful, particularly in programs that don't have as much training in dementia with Lewy bodies. The Lewy Body Dementia Association also has a symptom checklist on their website that people can go through and check off which of these things you're experiencing, so you have that ready for your doctor at the time of the clinic appointment. That's very helpful. So take-home messages here is, again, the differences between dementia with Lewy bodies and Parkinson's dementia. This constellation of motor and non-motor features can be very hard to diagnose, and everybody's different. That's really the main thing. Every patient is different. Not everybody has all of these things. So I'll finish up here with some comments on the patient's journey. As I've mentioned, that dementia with Lewy bodies is the second most common cause of dementia after Alzheimer's. It's heavily underdiagnosed. If somebody's 75 and has dementia, 9 times out of 10, the doctor is just going to say it's Alzheimer's without thinking too much about it. It's just the reality. Hopefully we're getting more out there for doctors to understand, particularly primary care doctors, but it is grossly underdiagnosed. Okay, we're going to move here. Another big challenge is that sometimes people have both. So sometimes people at autopsy can have both the synuclein as well as the Alzheimer's symptoms, and sometimes they can have the Lewy body with, I'm gonna move my thing over here, with vascular or small strokes. And so we don't always just see one thing. So it can be a combination of things. Okay, so we'll finish up here with know what the problem is, treat other conditions, and then support. So some people do really benefit from having that formal cognitive testing to understand whether this is more of an executive problem versus a memory problem. And so we do offer that in the clinic to do a full neuropsychological assessment. People don't always like it because it's like a 3-hour test and it really makes you, pushes your limits, but it can be very helpful for families to understand the problem. Make sure the doctor is paying attention to other things that can make it all worse, right? So I mentioned that the levodopa, something I use to treat one symptom, worsens 2 of the other symptoms. Make sure other doctors aren't doing those kinds of things. So again, thinking about infection, make sure thyroid function and B12 is treated, make sure depression is independently treated, and that people aren't just assuming, oh, you have a neurodegenerative disease, that's why you're depressed. Sometimes people need antidepressants. Make sure patients are hydrated, check for sleep. Don't just assume it's REM sleep behavior disorder. It might be sleep apnea. Someone might need a BiPAP for sleep. Check for hearing loss and encourage exercise. Support is incredibly important. And obviously you are all here, so you are obviously thinking about support. I want to continue to encourage that and consider a palliative care consultation. So I'm just going to end here in the last 2 seconds, I promise, just to give a quick plug for research, because that's something else that you can do to be part of the community and to understand better what's going on. And here we have out at the table, we have 2 observational research studies that we are talking about. The FacePrint one is the absolute easiest to do. It's a 30-minute one-time appointment, and you get a little gift card for being part of it. We're trying to develop and see if there is facial changes that can help to monitor symptoms when patients are away from clinic. So a common feature of Parkinson's dementia and dementia with Lewy bodies is reduced facial expression. So literally all anyone has to do for the study is watch videos that are kind of funny for about 15 to 30 minutes while their facial expressions are being recorded. And so it's very, very easy. It's actually quite a fun one. And so talk to Elena out at the table. In addition, we have the Alzheimer's Disease Research Center, which is a much more involved, much more comprehensive, but a really fabulous study that involves annual visits, including that memory testing every year and motor testing from a research neurologist. We do ask for a lumbar puncture as part of that, as well as brain scans. And this is really the reason we have a new biomarker today, is because of longitudinal tests like this and patients who are willing to do lumbar punctures. And we had about 15 years worth of banked CSF from all the patients who had donated so generously lumbar puncture, cerebral spinal fluid for research. And the moment this biomarker was available, I was able to get all of those samples tested and to find out and to validate that biomarker. So incredibly important to have that kind of research. And then we have one interventional clinical trial. So actually a treatment intervention that is being advertised out there. We also have a study for caregivers only, so healthy older adults, to help us to fine tune a little tapping device, which again is being developed as an at-home assessment of how motor symptoms are changing over time. But first we have to validate it in healthy older adults, so any of you can take part of that. And that's pretty much it. So final take-home message. Lewy body dementia is the second most common cause of neurodegenerative dementia, often misunderstood, a lot of delays in diagnosis. So it's super important for us to develop better biomarkers for people. It is often difficult to identify because it does sometimes also include Alzheimer's pathology. And it's very important to always be reviewing the medications for patients, because sometimes something that helped them 3 years ago might be making things worse today. All right. And yes, in fact, it does take a village, and that's why we're all here today. So I'm going to pass it over to Robin, and we're going to do the question and answer.
Okay, very good. Thanks, Dr. Poston. We have a lot of questions already on green cards here, and they include some Zoom participant questions as well. So keep them coming. I don't think we'll have time for all of them, but we'll do our best. All right, so keep the answers as short as you can.
Yep.
All right. Some people say that their physician, they bring their family member to a physician, and the physician dismisses the complaint because the person with potentially with Lewy body dementia compensates very well in a doctor visit.
Yeah, so this absolutely can happen. I think giving direct examples is oftentimes helpful for the physician to understand the impact. It's an important distinction that I try to teach my trainees, is that it's more helpful for me to hear from somebody rather than saying, oh, I have a tremor. Then it's better for me to hear, when the tremor happens, I can't do this. right? So impact, really think about it, like communicating to the doctor, not just the symptom, but the impact of the symptom. And that oftentimes will help to kind of get that, oh, wow, this is having an impact on day-to-day life.
What is the importance of an early diagnosis?
I think there are a couple of importance of early diagnosis. So one of them is just so the patient and the family don't feel like they're crazy. A lot of times patients and family members are like, there's something wrong. I know there is. No one's paying attention to this. Is it me? Am I wrong? Is it like, what is going on? And so just knowing that, like, yes, there is something going on. I did notice it. I have a name for it. It also helps you to anticipate the disease-specific issues that might come up with this. So for instance, those hallucinations are very, very uncommon in Alzheimer's disease, but quite common in Lewy body dementias. And same with the blood pressure drops, very common in Lewy body dementias, almost not common at all in Alzheimer's disease. So there are some disease-specific things that you would want to know about prior to them happening, just to be aware of.
Okay, we have 3 questions that are identical, so that sounds like an important one.
Okay.
Is Lewy body dementia hereditary?
Great question. Great question. Generally, no. There's no 100% causal gene. What I mean by that is that there are some diseases that if you have the gene, you will get the disease 100% of the time. That's not really the case with Lewy body dementia. There are a couple of genes that increase risk over time, in somebody's lifetime, but I'd say less than 15% of all people who are diagnosed with Lewy body dementias have one of those genes. It's quite uncommon. And in fact, research is being done to sort of put together this like polygenic risk score. So if we take like 30 different genes and put them together, does that increase the risk? So it's not, generally speaking, we don't think genetics are a major influence. Unfortunately for all of us, the number one risk of Lewy body dementias is age.
Okay, we have a lot of questions about the skin biopsy. Could you say just a little bit more about that?
Yes, so the skin biopsy, so they did some research that identified that in people who had, this was traditional Parkinson's disease, that when they took the skin biopsy and stained the tissue for synuclein, they could see that it was positive. And so it's not quite in those beautiful little like discrete Lewy bodies. It's actually kind of hard to find. It's a very manual procedure where they have to look at slide after slide after slide after slide. I actually just saw a presentation from the group who does this yesterday. It requires 3 biopsies, one from the distal leg, distal thigh, and then the back of the neck, and they look at all 3 of them. And sometimes just on one slide, they might see it. So if it's there, it's a good, like if it's there, it's there. Like if they see it, then it's definitely positive. But if they don't see it, it could be what we refer to as a false negative. They just didn't have the right slice. So a negative test is less helpful, but a positive test is pretty much 100% correct. So it's nice from that perspective. You can't test for anything else. Just the synuclein is the only thing you can test for, but it's very easy to do.
Okay, here's a lot of questions are good, and here are a couple about what medications can worsen the cognitive part of Lewy body dementia, and perhaps similar is, in the advanced stages of Lewy body dementia, is it best to back off of the medications and keep the medications simple?
Yeah, so I'm just going to broadly say any medication can worsen cognition. Antibiotics can. I mean, it's one of those things that as somebody's dementia becomes more severe, we need to worry about everything. The ones that are the highest on my list are anything that's sedating. So that's why that clonazepam really worries me at bedtime, because it's a sedating medication. Pain medications that are sedating. The second group that I think about is anything that crosses the blood-brain barrier. So anything that's actually brain active. Turns out it's very hard to formulate a drug to cross the blood-brain barrier. The brain is very protected. That's why when we get infections, the brain is usually not involved at all. And we call brain infections very special things. That makes it hard for us to treat neurological diseases because we have to get the drugs across the blood-brain barrier into the brain. But it's actually good in that most medications don't do that. So like thyroid medication doesn't cross the blood-brain barrier. It just affects the hormones in the rest of the body. Cholesterol medication does not cross the blood-brain barrier. So those are all fine. So those are on the safer side. So anything that causes sedation, which by definition crosses the blood-brain barrier, and then anything that crosses the blood-brain barrier, even if it doesn't cause sedation. And so that's something that you can always ask your doctor about, looking at the list and say, does this get into the brain? Because I'm worried this might be worsening cognition.
Okay, we have several questions here about REM, sleep behavior disorder, how it can precede motor symptoms for decades even. And a lot of people are wondering, how important is REM sleep behavior disorder in terms of the diagnosis? Some people say, oh, my loved one first had a Lewy body dementia diagnosis. They do have REM sleep behavior disorder. And then the diagnosis changed to Alzheimer's. And similarly, some people are saying, why do I need a skin biopsy or a DAT scan if my family member has REM sleep behavior disorder?
Yeah, they're great questions. And honestly, we're in this time period right now where we have formal diagnostic criteria, but the field is changing so rapidly with new information that the formal criteria kind of can't keep up with the new biomarkers, which is good. This is like 2 decades of intense research finally like paying off in the smallest way. Hopefully more and more to come. But the formal definition for dementia with Lewy bodies was that you needed like 2 of the 4 things between the Parkinsonism, the REM sleep behavior disorder, the fluctuating cognition, and the hallucinations. And so if someone just had one of those and it wasn't clear about the REM sleep behavior disorder, the doctor might say, well, I want to get that sleep test so I can check 2 boxes and feel more confident. That said, you can't rule something out. Like you can't say, well, you have REM sleep behavior disorder, so you don't have this. Because as I said, about 20 to 30% of patients at autopsy at least can have both Alzheimer's and Lewy body disease in their brain. And so having REM sleep behavior disorder doesn't rule out Alzheimer's disease. And I would just say in our clinical practice, people, when we saw that the doctors were flipping between the diagnoses and we looked finally at their cerebral spinal fluid, they more oftentimes had both. And that's why they were exhibiting signs of both. But we can't tell that 100% until autopsy or from the cerebral spinal fluid. That's the only way that you can tell if somebody has both the Alzheimer's and the Lewy body pathology.
Okay, thank you very much. We're going to have to end it here. We have so many green card questions. We'll try to address some of them that we can that are non-medical related. And even on the medical related ones, we can at least point you to some good resources.
Yes,
so we'll work with Dr. Poston on some follow-up for that. So thank you very much, Dr. Poston.
Excellent. Thank you all.